There are three phases of the perioperative experience. We have pre-op, which starts from the moment the patient decides to have surgery. It ends until the patient enters the operating room, which is pretty much the holding area. The intra-op period begins when the patient receives anesthesia and ends when the last incision is closed. The post-op care begins at the conclusion of when the last staple or when the last stitch is applied and the patient enters the PACU. So here we are. Patient's now in the PACU. So what are your nursing responsibilities? I know you're not expected to work in the OR, but since the period technically begins at the PACU, so we'll start from there. The focus of the post-op period is to continuously assess and intervene, assess for the patient's tolerance to the surgical procedure. So that involves, because the patient received what during surgery? Anesthesia. What else? Just anesthesia, opioids, what else? Sedatives, right? And then what did the patient have during the surgery? What was done to the patient? Okay, there was with or without intubation, because not all surgical procedures involve general anesthesia. So there was trauma, right? Okay, so there's trauma, there's blood loss. So we're going to assess continually the patient, the post-op patient, for their tolerance for all of those that they receive. So from trauma to all the medications that was given, right? And we'll do it system by system. First will be the report. So there's two possibilities here. You're the one giving the report if you're the PACU nurse, or in most instances, you will be the one receiving the report from the PACU nurse. So standard data, name, who is this, how old, what was done, and then after what was done, you do the rest would be how long was the procedure, what drugs were received, estimated blood loss, what fluids were given, anything wrong with the vital signs. Now, as far as the vital signs, if this will also include the lab work, last blood that was drawn. Now, for the vital signs, if the patient is not stable, should you receive the patient? Because remember, you're not in ICU, you're on a regular surgical floor. No. Okay, so you don't accept the patient. So you just don't say no though. No, nope, you don't say that. You just say you're concerned. So why are you not comfortable receiving the patient? So you justify it based on the vital signs, for instance, that this is not a stable patient. I should not receive them, right? So patient not stable obviously goes to the ICU because you can't provide the level of care that that patient needs. It's not it's not for you, it's really for the patient. Okay? It's not safe for the patient to be under your care on a regular surgical floor. So once they're stable, then they can come to you. So any complications that they encountered, we will talk about both, because there are complications to anesthesia, which we'll discuss under thermoregulation, and a few today, and then the surgical procedure itself. Any ongoing, because chronic medical conditions, do they disappear during surgery or after surgery? Okay, you still have to manage them. This includes not limited to diabetes, hypertension. So if a patient has any heart disease, kidney disease, lung disease, so you continue managing those post-op. Because for instance, in diabetes, what will happen to the sugar after surgery? Okay, usually rises, but because this patient has been NPO, correct? And before surgery, and will continue to be NPO for several hours afterwards, there's a possibility it may be low. So it can go both ways. Anticoagulants, because we have several people who are taking anticoagulants, they obviously were not given before and after surgery. So review when they can be safely resumed. Depends really on the drug. For instance, if the patient is on anticoagulants and let's say the surgery was elective, they usually come to the hospital a few days earlier because we need to wean them off the oral anticoagulants and place them on short-term anticoagulants. What is that short-term anticoagulant we're talking about? Heparin. Okay. Why heparin? Because remember, the patient needs anticoagulation, but keeping them on the oral anticoagulant puts them at risk for bleeding. So we can't do the surgery safely in that case. So they have to come sooner in the hospital, wherein they'll stop the oral anticoagulant, place them on IV anticoagulants, which only has, let's say, heparin has a 1 hour half-life. So 1 hour before surgery, we'll stop it. Patient goes to the OR, we cut them, and then we can safely resume it also a few hours after surgery. When it says reversals here, we're talking about what? What's a reversal agent for our opioids? Okay, naloxone. Okay. All right, so that's a general report. So if there's anything missing, if you can get it yourself, then fine. But if not, then ask questions. Okay, don't just say yes and okay all the time. So ask questions from the PACU nurse, because remember, once you hang up the phone, this patient is now yours. Are we clear? Yeah, you assume responsibility for the patient. Although you can transfer them again, but remember, when you hang up the phone, say, okay, that's a verbal agreement that you're accepting the patient. Okay. All right, let's go now to the system by system assessment. So the patient now goes to your floor, you receive them. So priority ABC would be airway. Now it depends on what kind of anesthesia was used for the procedure. So if it was general anesthesia, that means they were intubated, correct? So check the airway, make sure, because some intubation are traumatic, so they can have some airway edema and swelling. So if you hear what are signs of airway obstruction, what will you be looking for? So earliest would be? The saturation would drop. Okay, saturation, and then there will be some confusion, correct? Then within minutes, color will change. And then you'll also hear abnormal breath sounds like what? Wheezing and stridor. Anybody planning to be a CRNA here?
No. Yes, I am.
Why not?
Yeah, exactly. Why not?
They take you at a certain age. And I'm getting
That's not true.
I'm like, what?
federal line that you have to be young.
No. They'll take your money. Any school will take your money. You could be 65. They'll 80. They'll take you.
They'll take
You have money? Yeah.
No, I see how they said that they be looking at your age.
That's the military, not the medical field. All right, let's go now after airway. So go to, we have airway breathing now, circulation. This can occur from a variety of reasons. Number one is blood loss. Could also be from hypoventilation. Now, when we say hypoventilation, this also includes the intubation. Now, it's a natural phenomenon when we intubate patients, and you'll see this once you're on the floor. Say you called RRT and your patient was intubated. There's a phenomenon that's expected to happen. There's something we call post-intubation hypotension. The patient's blood pressure drops after intubation. So be prepared to administer vasopressors or IV fluids, whatever the doctor is ordering. Okay, so not only blood loss, again, from the intubation itself, it causes a drop in blood pressure. It has something to do with the hormones, okay, hormonal response to the trauma of airway insert, artificial airway insertion. then precision changes, and then pooling of blood. Remember, these patients are not mobile after surgery, so there will be decreased venous return, and that contributes to the low blood pressure. And the rest are, of course, from the anesthesia, the opioids, and the benzodiazepines that the patient received. So not just the blood pressure, because sometimes the patient has a low side blood pressure levels before surgery, meaning that's the patient's baseline. So you don't just base it on that, because the patient may have hypertension pre-op, and although blood pressure reading is normal technically, but if it's so far, let's say more than a 25% or 25 millimeters of mercury difference from baseline, is that significant? 25% or a 25 millimeters of mercury difference from baseline to, okay, that's always above or below, okay? Doesn't have to be below baseline, could be above baseline. And we just concluded shock, so watch the patient for all types of shock. They are prone to any of these types of shock after surgery. And we already know the most common signs regardless of the shock. What is the patient's blood pressure? Low. And then as far as the skin color, it varies, right? What type of shock? In the distributive shock, what will be the color? In distributive. Okay, warm and flush. So that, what are the three distributive again? Anaphylactic, septic, and neurogenic. Everybody else should have pallor and cool, clammy skin. Watch for hemorrhage. How would you determine hemorrhage? Because hemorrhage can be overt or hidden, correct? Right, they could be bleeding internally, or it'll be easy if they're bleeding externally. I mean, if there's obvious signs, you can tell. However, not all bleeding are obvious, correct? Yeah. So you look for subtle signs. Okay, start with the blood pressure will be, heart rate will be, okay. And then if it's GI bleeding, which we'll discuss later, what would be signs of those? Well, if it's stool, that'll be kind of late. So what would be earlier? Okay, so obviously coughing up or vomiting blood, okay, or distension of the abdomen. Okay. Other signs would be, of course, since this leads to hypovolemic shock, correct? So look for signs and symptoms again of hypovolemic shock. So shock includes mental status changes, correct? So here you go. So most of these are not new. You've already talked about these concepts in the past. I'll skip over table 16-1 because bleeding is bleeding. We discussed arrhythmias already last week. This can be caused by the trauma of the procedure, especially on the heart. So it's very tasking on the heart to have fluid shifts, the bleeding, and the hormones, correct? Because is sympathetic system innervated during surgery? Okay, so the epinephrine, the catecholamines will increase the heart's workload during surgery. Relieving pain and anxiety, because both of these are managed by drugs, and these drugs both depress the central nervous system. So give me examples of benzodiazepines that we routinely give. Okay, anything that ends in zepam, okay? Temazepam, lorazepam, diazepam. And you're familiar with opioids? We did this last semester. Take special consideration, because what's the average age or median age for our surgical patients? Yeah, our post-op patients. Who are these? Are they the young? No, most of our patients are old. Okay, so the majority of our patients are elderly. So take into consideration the doses that you're giving. Take into account the creatinine clearance. Okay, what is the patient's GFR, which we expect to be low. So don't keep administering medications if you don't see any effects right away. Because remember, there's some decreased kidney function here. So the kidneys cannot clear the drugs fast enough. So give it a little bit time, okay? Because before you know it, now you have a patient who's overdosing already. You will be given several choices of opioids depending on the facility. So you'll have to make decisions as to what you will use. What's the difference between IV and PO opioids? Okay, but are they long acting? No, that's the problem that's a disadvantage of IV. They work fast. Onset is fast, but they do not last long. So if properly used, usually it will give them only 2, 3, maybe 4 hours maximum. But take into consideration also tolerance, right? So you're better off really with PO. So as soon as the patient's no longer nauseous, consider the PO route. Plus, we have to discharge them at some point, right? Can we discharge them on IV? No. So it's better to start with PO as soon as possible. That way, it doesn't delay discharge. And we already tested also on equinalgesia, correct? What is equinalgesia?
Like the dosage we use for
To achieve the same, right? Correct. Okay, so always consider that the IV dose that was given should be equal to the oral that you're discharging the patient. Why is that important? Withdrawal, very good. Okay, what's the cause of our post-op nausea vomiting here? Absence of what? What's causing this? Paracelsus, correct? Okay, so regardless of the surgery, whether it's an abdominal surgery or a joint orthopedic surgery, there's no peristalsis. Okay, there's nothing moving, so or very little movement. So therefore, patient will have a lot of gas, a lot of stomach acid. So consider what will be drugs used to control this. Antiemetics. We'll get to the list under cancer because that's where most of our drugs are listed. They're not here. It's not on chapter 16. For controlling stomach acids, we'll discuss that when we get to peptic ulcers, right? But just remember that they're used for your post-op patients round the clock. Right? Because this is caused by little to no peristalsis, so besides medications, what would be the best way to get rid of it? Very good. Early ambulation. Do not baby your patients. You get them out of bed as soon as possible. Okay? Encourage them, of course. Don't like get a whip and then whip them out of bed. Provide encouragement. What would be number one reason why they would be reluctant to get out of bed? So what would you do? Okay, very good. So consider that. Okay, always consider or talk to the patient. Okay, wow. Is why therapeutic? Why won't you get out of bed? Is that your approach? Okay, well, how would you say?
You need to get out of bed.
Yeah, so just okay, all right. So therefore, give information first. Why, tell them why you want them to get out of bed very soon. Okay, so give the introduction. If you want, you can open up chapter 16. Okay, read the paragraph. or you have a teleprompter, for instance. Okay, so just give information why we want them to get out of it. So what can be eliminated or prevented by early ambulation? What complications? Number one is nausea, vomiting. Next one are blood clots. What else?
Heart, pulmonary, lungs.
Okay, no pneumonia, right? What about constipation? What about the, okay, circulation? What that means, blood clots are prevented. Okay, so almost all of these are eliminated by just one intervention, which is ambulation. And what's the number one hurdle for the ambulation? Pain. Okay, so both can be controlled, right? So you give them pain medication, a few minutes later, get them up and walking.
So what if they have a surgery?
Of course, that's an exception. So they're only taken out of bed once they are ordered to have, let's say, crutches. But well, not walking though. But at least they'll be out of bed to chair. Okay, so that'll be the first one. So if it's a limb amputation or fracture amputation, we do get them out of bed to chair. If it's a hip or knee, the first thing would be trapeze. So that's available in all orthopedic beds. So they'll have, you know what a trapeze is?
Yes, I hope they're moving.
Okay, so it'll be a triangle, right? And then they'll hold on to that to start moving. Later, we'll talk about complications with the skin, which involves dehiscence and evisceration, but that's a bit later. All right, so for post-op nausea vomiting, here are a few drugs. Look at the third column. This will help you decide which one you're going to use. And we will do the same when we get to cancer management, because nausea vomiting, CINV, chemotherapy-induced nausea vomiting, is a major part of cancer management. So stimulant is metoclopramide. Look at the action of this drug. Acts by stimulating peristalsis, basically. So therefore, if you have peristalsis, will you have any bloating, gas, or nausea?
No, if you have peristalsis, you'll get rid of it.
Okay, so you will get rid of it. So this is how that drug works. Brand name Reglan, metoclopramide, that's how it works. So what's a side effect of this drug? What's a side effect if it stimulates peristalsis? Can you use that to your advantage though? Yes, because is constipation also part of, okay, so yeah, so dual, right? Prochlorperazine, this is compazine. The most available and the most frequent route this is given is in a suppository. This is common in cancer management as well, because is it wise to give an oral medication for someone who's nauseous?
No.
Okay, so in cancer management, let's say at home, we don't have an IV access, correct? So that's why we use compazine. So in the ER, we use and I'm sorry, starts with an E. It'll come back later. Another is phenothiazine or promethazine. This is not very popular now, IV. So you can scratch the IV for promethazine. This is Phenergan. I'm not even sure if the drug book still says IV for promethazine. Not anymore because of the many cases of tissue necrosis. Because if this infiltrates, that's the number one harm this drug will cause. This is not very common. We do have hydroxyzine. This will be PO. and IM, but it's usually given PO. Scopolamine, the benefit here is it comes transdermal. So we'll put this behind the patient's ear. And you're all familiar with Zofran, right? Okay, so ondansetron, galocitron is very common. Now, how you again decide which one to use is look at the verb in the third column. Is this prevention or acute management? You can actually use it for both, right? Yeah, that can be both. Compazine or prochlorperazine,
Acute management.
acute. Promethazine, acute. This one, prevention. This one,
Acute.
acute. This one, prevention. This one, okay, therefore, so use them accordingly, depending on, based on their action. So therefore, if a patient's already in having acute nausea, in fact, they're vomiting right now, will ondansetron help them? Too late. Patient's already vomiting. You see what I mean? So use them accordingly. Now, how do you decide? You know, it's a post-op patient. So do you know, is your question if or when they get nauseous?
It won't.
When they will have nausea because they're post-op, right? So therefore, do you give this as needed or round the clock? Give this, use this round the clock, okay? Because it's more effective by preventing it. Patient's already nauseous. This will do the patient no good. Make sense? Yes.
It won't work for future vomiting.
Yeah, but not for this one right now.
Let's say if I vomit right now,
Mhm.
it
And
can't
you
help my vomiting now.
Yeah,
but
you
it
can
help
give this, but it's not managing this nausea. It will help later if you
later
get
on?
another one. Okay, that's what I'm saying. So that's for nausea, vomiting. Let's go to the next. Consider this one, bariatric considerations. What's the risk for all of these complications if your patient has a BMI of 30 or more?
Separation of the wound.
Okay, so a lot
infection of
more,
the
correct?
wound.
Right. We'll talk about those. No, let's do it now. So increased risk will be expected in bariatric patients. These are the following: DVTs, pulmonary emboli related to the DVT, and plus, are they likely to be diabetic as well?
Yeah.
Okay, so that will also affect wound healing and increase risk for infection. And I'm not saying all, but majority of our obese patients do have obstructive sleep apnea. This section here is usually applicable for same-day surgery patients, meaning they walked in to the OR and they also leave the same day. The latest they can stay is probably overnight. So the discharge here, what would be the basis for the patient being okay to be discharged?
Stable vitals.
What else? Do all of them have to be,
Minimum aberration.
because there will be, does a nausea, vomiting, constipation prevent them from leaving?
Yes. No.
So I can't discharge you?
You could discharge them.
If you're nauseous?
Medicine.
Okay,
Yeah.
alright. Correct. So therefore, our basis is the vital signs, right? And it's not also based on, oh, I have a ride. Yeah, who cares if how many Ubers you get? Okay, it's really based on, are you stable? Because do we have to feed them before they discharge?
No.
Not
Yeah.
necessarily, right?
Oh.
I mean, no, as far as this section here, like I mentioned earlier, this section only talks about the same day surgery.
Oh,
All right, same day surgery, right, and which they go home the same day. Of course, for regular patients, so for inpatients, I mean, that's a necessity, of course, because can we send them home if they're not eating?
No.
No, you have to be able to eat, right?
What are we the same for the patient? that-
No, because for same day surgery patients, we can't wait that long because they typically still don't like to eat anyway after the surgery.
How many hours? 12?
Less than 24 hours. There are standard post-op orders, but then there will be some specific ones, especially for orthopedic procedures. This is especially important for whether or not there is weight bearing on the limb involved. If it's not orthopedic, meaning it's either abdominal, thoracic, or well, that's pretty much it, right? Because those are the most common surgical sites. So we've got either a thoracic incision or a abdominal, and then any other orthopedic. So there will be activity restrictions, weight restrictions about how much you can lift, and they will all be specified at discharge. Okay, so now we go to inpatients. It'll be the same as far as the handoff report will be the same. So now let's go to the first few hours nursing care, chart 16-4. So same thing, ABC. So look at airway, breathing, and then vascular complications, which involve the prevention and early detection of blood clots. Whether or not they have a Foley will be added to the plan. What's the maximum again for the Foley to be left in? What's the standard? We discussed this last semester, right? And the UTIs, COTI. That's the central line. That's the central line dressing. What's the maximum for Foley catheters?
24.
Not 72, 48 now. 72 hours was about 10 years ago. It's been a while. For in the last 10 years, it's been 48 hours. Okay, so the latest Joint Commission remember Joint Commission made core measures? Okay,
Yeah.
so core measures for COTI is 48 hours. COTI prevention, you know what COTI is, right?
Yeah.
Okay,
Catheters.
all right, very good, children.
But wait, so they're not supposed to have the catheter in for more than 2 days? There's a lot of people who have to for way longer.
Well, we're talking about chapter 16, so this is for surgery purposes.
Surgery.
So it's 24 to 48 or just 48?
48 maximum.
Okay.
If the patient needs it, then meaning there's another reason why they need the Foley, make sure you have an order and it's documented. On Epic, the notification will not stop every time you access the patient's chart. The pop-up will appear asking you to document on the Foley. Okay, this patient has a Foley, and then it asks you for a reason. What's the indication? Until you have a satisfactory answer, that meaning every time the patient has a Foley more than 48 hours, that pop-up will appear, right, on Epic. And I'm sure it's the same with any other AHR because they really want to get rid of or prevent COTI. Right. Yeah, of course, the sooner the better, but the limit, since it's 48 hours, so that again, that pop-up will appear asking you to document. Okay, justify. Why is the Foley still here? Okay, why is it still in? It's been past 48 hours. So here are our not limited to, but these are the major complications we will be facing. There are expected like these, for instance, and they're predictable. The UTI is not listed here, but we'll include it. So what would be in your opinion, when would these appear? So let's say we have the first 5 days. Which one will you anticipate within the first 24 hours?
Well, and maybe additional.
To help you remember these complications, just remember the acronym WWW. Okay, so the 3 W's are wind, water, and wound. Wind, water, and wound. Wind. Okay. Wind refers to air, which is pneumonia. This pulmonary infection here is pneumonia or hypoxia. Okay, so that's wind. The water will be UTI. That will be the second. So wind will appear within the first 24 to 48 hours. That's pneumonia. Next would be water, which is UTI. So that's why, what's the limit again for the Foley? 2 days, because we know UTIs usually form within after the 48-hour period. So between 48 hours to 72 will be water, which is UTI. And then the wound will be around the 3rd or 4th day. We typically don't expect incision, okay? I'm not talking about any other infection, but for an incision to get infected, it doesn't happen during the first 3 days. How? Because we did sterile technique, correct? We did very good skin preparation. This is 2023. We got it down pat already. So if somebody made a mistake and the patients won't get infected, it won't happen during the first 3 days. Usually appears around the 4th day. Okay. That means, is it a hospital-acquired infection? Yes. Therefore,
Still in there.
correct, meaning it wasn't present before surgery. So is it good?
So,
That's bad. It reflects poorly on your quality of care. So do we want this on our cases?
no,
No, it's embarrassing. It actually has a financial impact on the hospital. Okay, there will be implications on reimbursement because you have a surgical infection. Okay, that should not happen, right? We have good sterile technique, good asepsis. It shouldn't happen. But if it happens, it will happen around the 4th day. So if this happens during the first 3 days, that's not actually bad financially, because that means, was the infection present? Yes, it was present somehow, just not discovered. You understand? Meaning that infection, if it happens during the first 2-3 days, it didn't come from the hospital. It was present somehow, or it could have been present from another source. Okay, not a surgical wound. Does that make sense? Okay. And part of these will eventually get infected if the surgical incision opens, or in the case of abdominal incisions wherein pieces of bowel come out, then it'll be evisceration, which again, they could be infected again. Okay, respiratory. So this is referring to, so what are our interventions for this one? So it's already here for preventing respiratory. So that's preventing this one. What are your interventions? Okay, so we've got the incentives parameter. So while we're at it, how do you use it? Thank you, Jessica. Can you demonstrate? That cup there is your incentives parameter. Show us how to use it.
You have to blow it very hard, right?
Thank you. Anybody else have different instruction?
Isn't that the one you inhale?
Okay, so we inhale. Okay, now the objective, the purpose of using the incentives parameter is to what? To expand the lung. Now, we can't expand that lung if we're blowing into the device, are we?
The peak go with the blow.
Okay, so show me who said, oh, Roe versus Wade.
Wow.
Can you tell me how to use the incentives parameter? Can you show me?
I don't know how
You
to
said
show you.
inhale. Okay, so you inhale.
Just inhale.
Yeah, just inhale into that Apple Pen. That Apple Pencil.
I'm gonna inhale to, but I'm not supposed to put your lips over the thing.
Okay, and
You inhale and,
how? But this is important.
right?
No, that's drinking noodles. So how do we use the incentives parameter?
Like that.
How do you do it?
That's noodles again.
You literally inhale, suck in,
Okay, good
You
thing.
show us.
All right.
and then you gotta hold it.
Did we discuss this on our New York clinical?
Or you just do that. You breathe slowly in and then you blow out as hard as you can.
No, you inhale and you hold it.
So this one is the inhale one, sorry.
All right, so let's not embarrass ourselves, all right? Okay, so the way I best remember it is you yawn into the incentives parameter.
Really?
You yawn
That's
into.
not what we do.
How do you yawn? Do you yawn like this? You yawn like?
But when you yawn, you don't inhale air.
Yes, you do.
Oh, you do? Cause I just showed that I did it. Yes, you do in the beginning.
That's why you. That means.
That's.
Now I'm wondering. No,
You're-
yawn. Make yourself yawn.
That's what you
No,
do.
That's not yawning.
You're breathing like it.
Okay, let me demonstrate. So if this is the. See, this is the mouthpiece. So exhale first. Exhale, and then you put it into your mouth, and then take a slow, deep breath.
You do not yawn like that.
And then that ball will rise, correct? Slowly. As deep as you can. And then slow exhale normally.
Next time you yawn.
Right? Are we clear? All right. Next question. How often do we use it?
Oh, I think I told every time I watch this now. You're right, I see it. I think I told it 8 to 10 times.
10 times every waking hour. 10 times an hour while awake.
Wait, what?
10 times every hour.
Oh, every time.
Why 10 times? Okay. If you do this more than 10 times, what will happen? Try inhaling slow and deep like that consecutively. See what happens. Okay, you will pass out. And plus it will be ineffective. Okay. So you're going to use it only once every 6 minutes. Okay, 10 times every hour is once every 6 minutes. Are we clear?
Yeah.
Okay. So the patient has to rest in between. Don't do it consecutively. Again, your efficiency drops and then it becomes useless. Becomes harmful actually.
Yeah.
So besides incentives parameter, what's the other intervention for this? Deep breathing. Okay, so deep breathing exercises and coughing. Let's say the incision is in the abdomen. What do we do now? Okay, so you splint the incision with the pillow. What's another intervention to prevent pulmonary complications? Walking, very good. So incentives parameter, deep breathing exercises, and the walking. All right. So that covers everything. So we have coughing and then ambulation. Now, some patients will have a do not cough order. What will be in contraindications for coughing? Any head condition. What structures are inside your head? Okay, so you have your brain. What else? Your nose, correct? So any surgery to your nose, to your ear, to your brain, no coughing allowed. Are we clear? In fact, we give them cough suppressants. Clear? Okay, we give them what's the we give them lidocaine, okay, to suppress the cough same thing, you know, when you have the endoscopy, yeah, we spray you with lidocaine. Are we clear? Okay, so only the head. Any procedures done to the head that includes the mouth, the nose, the ears, and of course the brain, no coughing allowed. Pain management, we did that a whole section last semester. I can still ask you though, complications specifically for opioids, okay, opioid management. Well, how to use basically. And you know PCA, right? Yeah, we did discuss PCA. We discussed ambulation and activity. Okay. So if the patient can't ambulate, what can be the best next thing? Okay, either active or passive range of motion in bed or on the chair. Orthostatic hypotension. Let's say you have an order to measure orthostatic blood pressure readings. How do you do it?
One laying down, sitting.
Okay, very good. Next question. How far apart?
Oh, you mean time?
If you do 5 minutes, is that an accurate reading?
No.
Because what are we actually trying to assess when a doctor orders orthostatic? It's a heart evaluation, correct? It's a heart assessment, meaning is the heart and the blood vessels able to respond to the changing metabolic requirements from laying to sitting to standing? Are you actually evaluating that accurately if you have the patient, if you do the measurements 5 minutes apart? It's not, because now the heart had time to catch up, okay? Because what do you normally do? When you get up in the morning, do you like rise, sit up for 5 minutes?
No.
And then get up and then rise for 5 minutes? No, you go right away, right? So therefore, it's not reflecting the true heart assessment. Do you understand?
Yeah.
So how far apart should the readings be?
Right away.
1 minute. Okay, only 1 minute. So laying down, take it within 1 minute. Rise, check again, meaning on the record, on your epic, when you chart it, it should reflect 1 minute intervals. Are we clear? All right. Because who works in hospitals here? Your Dynamaps are connected to the epic, right?
Yeah.
Meaning when you save it automatically, yeah, so the time reflects what time you took it, how far apart. So if the doctor sees on the charting, oh, this is not accurate, they'll order it again, repeat it, because it's not accurate, it's not 1 minute apart. Okay, so if there's like several minutes between them, they'll order it again. Okay, so exercises in lieu of ambulation as applicable. Toileting. Depends on the activity level. I mean, you know how to place a patient on a bedpan, right?
Yeah.
Or onto a commode. Okay. Okay, let's go to incision now. What kind of wounds are surgical incisions? First intention or secondary intention? Why? Why primary? Yeah, primary or first intention.
Because you intended to make it. You did it on purpose.
Oh, yeah, another question.
Okay. What these mean is, so why is a surgical incision first intention healing? This means that the patient lost little to no tissue. Are we clear? They didn't lose, or if they did, very little, negligible amount of tissue was lost. Okay, so therefore, how many steps does the body need to take in order to heal it? One step. Because you didn't lose any tissue, so therefore, the only thing to do is to close the skin. So that's why it falls under primary or first intention. Secondary intention is a larger wound, meaning it will take time. The wound has to heal from the inside out, meaning these are wounds that have the patient lost considerable tissue. Okay, so two steps. The patient has to heal the wound, grow tissue first, grow granulation tissue, and then close the skin. Tertiary would be an infected wound, because now we have three steps. We have to treat the infection first before granulation can grow, before the skin can close. Clear? So that's tertiary. So it's not because of the intention, all right? It's the steps. How many steps will the body take in order to heal it?
So I have a question about that. So pressure ulcers, are they really second or they're
secondary? They become tertiary if they're infected pressure ulcers.
Okay.
All right, here are factors that will affect wound healing. We'll discuss the steroids and immunosuppression next week after the exam. So table 16-3 are the factors that affect wound healing, meaning they will delay it, correct? Number one is age, hygiene, and whether or not there is bleeding. Temperature, and because hypovolemia affects circulation, correct? Okay, and blood pressure. Then we've got local factors, edema. So this is where obesity falls under, because they will have the delayed wound healing. Because can the drainage drain normally if you have obesity? No, there will be pockets, right? So they will be located in small pockets, right? So that's why, correct. So we usually have drains placed in our obese patients. That way it will facilitate drainage of drainage. Okay. To facilitate drainage of the drainage. Yeah. Give me another word. Oh, removal of the drainage. Okay, facilitate removal of the drainage. Oxygenation. So this will also not just the, not oxygenation as in breathing, but oxygenation as in delivery. So patients who have poor circulation, say arterial disease, for instance, okay, or venous disease, so that will cause edema, right? So arterial, of course, will result in poor circulation. Venous disease will result in poor drainage. So the more edema you have because of chronic pooling of blood in the legs, so that will cause complications, wound complications.
I saw a man's leg like that. It looked, you could see the muscles and everything just from
the ulcers, right?
Yeah, it looked really bad.
As mentioned, so these drugs here, or hormones, which our patients next week will have, they either have endogenous or exogenous steroids, anticoagulants, and antibiotics, of course, as applied. Now, most surgical patients will receive antibiotics during the first 24 hours. Why? Okay, so that is prophylactic antibiotics. Is there an infection? No, we're trying to prevent one. Okay, why do they need it with the surgical procedure?
They are risk for
Okay, because it's invasive. All right, very good, children. And these systemic disorders here will likely affect healing again and again because of steroids, immunosuppression, same thing. And here are the following. These are present usually again with obese patients. Okay, they tend to have COPD or obstructive sleep apnea, all of which cause coughing, and that produces a lot of pressure on the incision. You're familiar with drains, correct? You did this in fundamentals?
Yeah.
Okay. So are these passive or active? Which one is passive here? The Penrose or the JP? Which one is passive drainage?
Passive is pulling it out, right?
Passive means by gravity.
Oh, the JP.
Okay, Penrose only drains by gravity. So what's the best position for this patient? Based on that,
Upright.
okay, upright or sitting. That way you drain by gravity. This one, does this drain by gravity?
No.
Technically, yes, but what's the,
Suction.
okay, where is the suction applied?
In the bowl.
By the bowl. So therefore, for this to apply suction, what should you do
You have
to the
to
bowl?
squeeze it in.
So therefore, a non-compressed bulb, is it applying any suction?
No.
So if it's no longer compressed, that means it's full of
Here.
it's full of drainage. Okay, that's why it expanded. So therefore, it's time to
Remove it.
drain it and then compress it again and cover. How about this one? This is called a,
Oh, is that a one?
this is a hemovac. Does this drain by gravity, passive or active? Or suction? Suction. So this works just like the JP. It's bigger, so therefore it has higher or more suction? More suction. So this one has springs, right? Right here. It's not shown here, but there would be springs here, works like an accordion. So compress it, cover the opening, and then it will apply suction. Okay. So this is the Jackson Pratt.
We still use the one that's seen in the hospital still,
Which one? The
the letter C.
hemovacs, yes, or hips and knees. Yeah. Mhm. Yeah, so for,
Yeah.
I mean, the black sponge.
Yeah.
The machine for the hemovac.
We'll discuss wound vacs separately because it doesn't really belong here, because that's part of chronic wounds. Okay, chronic wounds. So maybe we'll do it in lab.
I know, right?
Because you have to get something.
So since we have pictures here, let's discuss it now. Okay. What you're seeing is Ashling here? She didn't make it back in.
She's on her way.
Okay. So these are chronic wounds. First of all, we only apply wound vacs on clean wounds. All right, you can't use this therapy on infected wounds. Okay, because it will trap the infection. So once the infection is clear, then we can apply the wound vac machine. Now, how does it work? Okay, so this is the opening, right? This is the wound right here, the one that's all covered. Now, you don't have to cut the foam perfectly to this size. It can be imperfect. And another thing is somebody did a bad job on this one, because see how along the edges, it's not covered by the foam. Okay, there should be foam here as well. Okay, so what happened here is you irrigate the wound, of course, with saline, sterile saline. So you irrigate that, and then the wound must be the only one that should be suctioned. Okay, So therefore, we apply the black foam only on the open wounds, not on intact skin. Because when suction is applied, what will it do to intact skin?
Break it.
It will break it down. Okay. So the strategy to prevent that is, you see this clear dressing you see all around? Okay, it's not very obvious out here. It's obvious here. See this little plastic? All right,
Close the.
correct. So we put the clear drape from here to here, and then using sterile scissors, we will cut and expose the wound. All right, meaning we have drape here. We put the drape from here to here. We put drape. Doesn't have to be one piece. It could be several pieces. Okay, don't worry. Whatever size drape, because we have about this much, this big black paper like this. These are the size of our drapes. So you just put that there on my abdomen. Okay, however many you need to put. And then we're gonna cut and expose the wound. Therefore, the peri wound, the skin edges, do I have drape there?
No.
No. Okay, so let's say this V here is my open wound. I put this clear drape here, and then another here. When I cut to expose the wound, I cut over here, exposing the wound. Do I have drape here?
Yes.
Yes, I have drape here. So therefore, even if my foam was not perfect, it's not perfectly cut, and it sits on intact skin, will it suck on my intact skin? It won't, because I have a drape there. Make sense? All right.
But
And
wait,
then, yeah,
you leave the drape, that person don't have a drape on.
okay.
They do.
Okay, let me explain again. This clear tape here, you see? This clear dressing, you see?
Yeah, I know.
That's what we call a drape. Okay, so this, like a tegaderm. These here.
Oh, okay.
So the drape is like a tegaderm, a
Yeah.
very large tegaderm. Okay, so we have tegaderms this size or sometimes bigger. So that's what we'll put. Again, we'll cut and expose the wound so that we can put the foam. Clear? Okay. After we put the foam, we'll put another drape over the foam. Right? And then we'll put you see this little disc here? So we'll cut a little opening on the outer drape.
Yeah.
Put this disc on. This is connected to the wound vac machine, which is a vacuum. We turn it on and it will look like this now. All the air will come up, in, out, and this will be really tight and nice. Okay. Yeah, so like a vacuum seal. Okay. And you see this one here, how did they do it like that perfectly? Same exact way. So you just cut the foam and you can even track it. So let's say it's in a spot where, let's say right here, is it good to have the disc? Let's say the wound is right here. Is it comfortable to have the disc there? I mean, your pants are there. No, so I'll put the foam there, but I won't put the disc there because it's gonna be in the way of my pants, my waistline. I'm gonna track it. So here you can track it anywhere as long as you have a drape. So just put tegaderm here, put more foam here, so it doesn't suck on your skin, and I can put the disc here. It will still be connected to my wound, but it's not sucking on my skin here. It's sucking on the wound. Does that make sense? You understand what I'm saying? Okay, so it's an art basically. So when you work in wound care, which is not bad really, make good money on wound care. This is very nice. Okay, if you are into this, if you want to be certified, 6 months, that's it.
6 months. So if you do.
BSN training for 6 months, take the exam, you're certified.
So
Good to go.
Orientation for like one patient, they come into the house and they hope you know how to do it. That is possible.
No.
Like,
I mean, you can do the job, but you're not certified. You don't have the degree. Because once you have the degree, you can start your own business. Yeah, you can have an LLC. Let's say we'll call it Johnny Wound Care. Johnny and Rogers Wound Care. You go into business together.
My name is Rex.
Instead of working for the hospital, we're our own bosses. And we bill the insurance directly.
Yeah, Medicaid, yeah, that's what I want.
And I'm manage the money. And
Yeah, we'll hire them.
I'll manage the money.
We'll hire them, okay? Yeah, we'll pay them by the hour.
No, I'm gonna manage the money.
You and me.
I'm gonna pay y'all.
Ain't no way, ain't no way.
Yeah, I'll manage the money.
Body thermal regulation, very important because is it warm and dry in the OR?
In the OR? No, it's cold.
It's freezing down there. So most likely patient will have hypothermia, so make sure you maintain that. We already did nausea vomiting, so we'll skip that. And here are your, because the wound is not healed, right? Before the patient's discharge. Is the incision healed at discharge? No. So they'll come back. All right. So sutures are removed typically between 10 to 14 days. How long? 10 to 14 days. Same thing about sutures if they're not absorbable sutures. Very important is please remember to take it out. Sutures. Okay? Because if you don't take it out, skin will grow over the sutures. And it's as if the patient doesn't have any sutures. Meanwhile, is it a foreign body? Can it cause infection? Are we clear? Okay, very important, okay? Don't forget about the sutures. It happened to, if you work in home health, you'll see horror stories like this. No, just lack of coordination. Somebody messed up. Somebody didn't do their job. Okay, it's supposed to be part of the follow-up. Okay, the case manager usually. So somebody missed the boat. And patient paid for it. Now the patient septic. Big lawsuit too. You can read, so I'll have you, okay? As long as there's nothing open, I mean, sutures are intact, incisions intact, there's no open things, you can shower. All right, you can take the dressing off, patient showers, clean it, rub it with soap, keep it dry, okay? For orthopedics though, those surgeons are, because it's a multi-billion-dollar industry, they have 7-day dressings. Some of them have 14-day dressings, which means the dressings come off at all. No, so therefore no restrictions. You can shower, whatever, but no bathing. They don't advise bathing, but you can shower. And nothing to do with this, the dressings. The dressings stay on. Okay, they're very sticky. They literally last 7 days. If it says 7 days, it will stay on for 7 days. 14 days, it will stay on for 14 days. Voiding. If there's urinary retention, now please do investigation whether it's urinary retention or oliguria. Are they the same? No. Oliguria means patient's not making any urine. Urinary retention, is that the same? They made urine, it's just stuck in the bladder. Okay, 2 different problems. So 2 different interventions. So you investigate. How do you know which one is which? Let's say a patient hasn't had any urine output for the last 12 hours. Okay, investigate. Where is the urine? Right, so if after your bladder scan, there's nothing or very little in the bladder, that means it's oliguria. It's a much more serious problem, right? So it's a kidney problem, not a bladder problem. And then of course, report accordingly. So if it's urinary retention, usually what's the order we anticipate? Or at least a straight catheterization, right? And then if it's oliguria, then investigate, do blood work, kidney function, and then do ultrasound if necessary. Safety, this is not only for falls, but also infection and bleeding. And support, I really have no questions. If I do, it's about therapeutic communication. All right, see, here are the complications system by system. We kind of covered all of them already. Interventions should be practical. What are our interventions again for these? Very good. Ambulation will cure all of them. What else? They can't walk yet.
Barometer,
What else?
passive.
Okay, very good. How about these? So questions will be assessment and interventions, okay? So signs and symptoms, how do you know that they're happening? And then interventions. You can read. I'll go to the management of dehiscence, and because for DVT and PE, we have a separate chapter for that, don't worry. Let's go to this one. Okay, so management for this. Which one is dehiscence? Left or right?
Oh, no, open, the one, yeah, the evacuation is it coming up.
Evacuation is whatever the.
Yeah, which one's evisceration?
The first one.
Evisceration. Dehiscence. Okay.
That's the.
Wait, what? Say that again?
Dehiscence, evisceration. Signs and symptoms. If the patient has a dressing and you can't see it, this will be the report from the patient. So either something gave way and then something popped. Those are the descriptions. Okay. Or you may have a sudden gush of bloody or semi-bloody drainage. Okay. Interventions. So you suspect dehiscence and or evisceration. What's the first action? Let's follow the textbook. What does it
The
say?
head of the bed. Instruct the patient.
That's the first action. Are we clear? What's the first thing you do? Yeah, same thing. If it's dehiscence, then no need to cover. But if it's evisceration, then you cover.
Cover and cold.
Correct. So again, this in this order, okay? So if you see that it is happening, what's the first action?
Lower the head of the bed.
And tell the patient to.
Keep still.
Then what's the next one?
Then you cover it with a wet saline.
And
Dressing and then cold session.
clear? All right. This is evisceration. If it's dehiscence, then there are no intestines coming out. This is dehiscence, this is evisceration. And this one here is management of evisceration.
But are we also covering the D1? The dehiscence. We cover that one too.
Correct, but there are no coils of
Right,
intestine.
there's nothing coming out.
But we should still call that.
Correct, yeah, in either case, yeah.
Yeah.
You'll see delirium, especially in the elderly, or if it occurs in the non-elderly, younger people, then these are the possible causes. All right. What is delirium? Is it the same as Alzheimer's dementia?
No, it's temporary.
Okay, this is acute also, right?
Yeah.
Sudden. They were fine a minute ago, now crazy. Making any sense? We are done with post-op. Okay.